So just to throw a tiny wrench in the equation here. So one of the things, like I think we're all in agreement about the research, what we know right now, and what can be proven and what can't be proven. But has anybody ever seen a perfect research study? Right? Yeah. So we're always based on the limitations of the study, right? And we do the best we can. Right? We're double-blind, controlled studies, random, controlled clinical trials. That's the best that we can do. And the other thing is that there's always systems and things that are changing, right? So, I mean, Invisalign MA is one example of that, right? We have a new functional appliance. So now it's like all the research that we ever did. Now, do we have to redo everything? No. But, as we start making claims about a new product, yeah, we need to know specifically how that works, because anecdotally we can say, all right, well, this makes sense. It does the same thing as a twin block. So, of course, the changes are going to be exactly the same as a twin block. But you can't really say that. So, now we get into the world of skeletally anchored functional appliances, right? Where we have something attached to the bones themselves. Now, this is not an entirely new concept. Who can cite or name a skeletally anchored functional appliance that's been around for years that not a lot of people do? I've never done one personally. But does anything come to mind? If I say Hugo de Klerk, does anything come to mind? What's that? Nothing? I put some plates down. Yeah, bollard plates. You guys heard of bollard plates? Yeah, so basically, he's been doing this for, I think he published on this, it had to have been close to 20 years ago. So basically, they take the kids, they'll put plates in the mandible, they'll put plates in the maxilla, and they'll run elastics, right? Orthopedic type force elastics up to, 24, 28 ounces per side. Pretty strong elastics, right? Plates can fail, all that kind of stuff. So we know a little bit about what that can do, and certainly that can move the maxilla at least. I think the data on the mandible is a little less clear, but most of these cases are used for protraction of the maxilla, and 100%, you can get way more protraction than we ever thought we could with, reverse pull headgear or other things that we used to use that are anchored to the teeth, right? So now we have the question is like, well, what if we're trying to use skeletally anchored functional appliances to help move the mandible forward, or anchoring to the maxilla? Is that going to mean that, now, before we get to our class 2 correction, more of that change may have to happen in the mandible if we are going to anchor to the maxilla, right? So if we anchor to the maxilla, let's say with an MSE, right? So we have anchorage to the 6s, and we're running a MARPE, or we're running a Herbst, or we're running something. We're not going to get the same molar distalization, probably not next to any molar distalization, because that's anchored to our skeletal system, right? So you will have distalizing force on the upper jaw, but if it corrects, it's going to have to correct mandible forward in some way. Either the jaw, could be positional, right? We can have cone beams to check that, to look at that. Could be the teeth flare out too much. That wouldn't be good. You push them right out of the bone. Or it could be that maybe with that extended period of time that we do see more jaw growth. Now, I'm not here to tell you that that's what's happening, but this is why these questions come up. I think you do have a few people in the lecturing world that sell products, and they say whatever they need to sell products. I think the majority of speakers who are out there, have ideas and they have experiences. They see things in practice. I went a long time without doing any functional appliances just because of the research that I'd seen on it, right? And I'm like, okay, well, that just seems like a headache. And, meanwhile, I see all these other docs who are very well respected using Herbst, using Mars, using, X, Y, or Z. And I'm just like, why would they do that? I mean, they know the same research that I do. And so I was like, okay, well, all roads lead to Rome, so to speak. There's a lot of ways you can correct a class 2. So I started using them more for my cases that I had a hard time correcting class 2s with, right? I mean, when you've got a centimeter or more of overjet, that's not an easy case. And so, let's look at how we can make that an easier case, whether it's mandible growing or maxilla back a little bit or teeth moving or whatever. Like, I just need to get through the case in a way that's easier than class 2 elastics, right? Or, CS springs or a Forsus or whatever else I was using at the time. So we're going to go through that, but that's in my opinion, why we will never have a consensus about what's happening in orthodontics, right? There's always going to be two sides to the story. And hopefully you can filter through with a sound understanding of the research. You should be able to filter through those practitioners who are speaking out their ears, right? Who are just blowing smoke, right? Because they're going to be saying multiple things that just don't add up at all, right? But those guys who are presenting and helping you to understand, like, they're going to be presenting you things that they don't even understand yet, right? And hopefully together and over time and further research, we get to the point where we do have a new consensus. There's a lot of things that we learn about and believe now that 30 years ago we would have said, no way. Like, that's not what's happening. Our understanding changes as the data changes. So a little bit of a history on functional appliances. I mean, we'll go back. Does anybody know where or how functional appliances, or when, like, where did this idea come from? What was it? Yeah, you got to get a clue there. At least you guys know geography, right? Anybody know when, like, functional appliances were born? If you had to guess? In the 60s? Which 60s? You were close, yeah. So 1883 was like the first concept of, like, hey, maybe we can shape or change the jaws in some meaningful way. So this is something that I am pretty passionate about. Like, no one ever talks about dentofacial orthopedics. Like, no one ever said, like, you ask you what you are. It's like, oh, I'm an orthodontist. No one ever says I'm a dentofacial orthopedist. Meanwhile, that's 50% of our title. It's 50% of the title on our textbooks. It's 50% of the title on our main journal, American Association of Orthodontics and Dentofacial Orthopedics. But yet we spend so much time focusing on orthodontics, which I always associate more with the teeth, than dentofacial orthopedics. And I think that's a problem, right? I think that dentofacial orthopedics, if you had to pick between the two, are probably more powerful and more important than our ability to move teeth where we want them, right? But in order to be able to do that, you have to have a sound understanding. And I think the main reason that we don't focus more on it is because there's such a strong belief of how limited of an effect that we can have on it, if that makes sense. And so it's like, okay, well, genetics determines growth. Okay, whatever, like whatever. So yeah, we'll just do what we can. And at the end of the day, I mean, they're going to grow how they're going to grow. I mean, I personally don't believe that. I think that we have a huge influence on the jaws. And I think that now more than ever, we can exert more influence on the jaws than we ever have been able to. And I think that as we continue to research this, and as we continue to get more and more data, we are going to learn more about growth from a more global standpoint. I mean, the AAO still recommends, child see an orthodontist at the age of 7. The reason for that is dentofacial orthopedic, right? Yeah, you might have an occasional patient that has a little anterior crossbite with no jaw problems, but typically the kids who are younger that need orthodontic treatment have jaw problems. They have jaw size discrepancies, upper jaw is set back, too small, all things that we correct orthopedically. But 7 is it. We don't really have data under 7, right? I think a big reason for that is that under 7-year-olds are freaking hard to treat, right? And so, pediatric dentists, that's great. You guys are equipped to treat these kids, but you guys don't have the orthodontic knowledge. And orthodontists are like, I got into ortho because I didn't want to treat little kids. You know what I mean? And so it's like you have this gap of knowledge and understanding. But the cool thing is that this gap is becoming more exposed. And I'm not going to go into the details about why that's happening because there's controversy as far as that's concerned. But there are people getting into this game who are becoming, because orthodontic and dentofacial orthopedic education is more accessible now than it ever has been, right? I mean, you can become probably 70% of an orthodontist just finding stuff online if you really want to, right? Search up this, search up that. I mean, like, you can learn a ton online that you never used to be able to do. So now you have practitioners that aren't orthodontists who are comfortable treating kids, who are digging through the research. And again, I'm not saying all these people, that's why it's controversial, not all these people are doing it the right way. Some are selling fish oil and just doing it to make their practices better, but you have many of them who are looking into this because they believe in it, and they're doing it the right way, where they're looking at the research and they're willing to take on the risk associated with treating a group that used to be untreatable or not recommended for treatment.
I just want to say that I think overall I feel in the profession, and again, I don't know what I'm talking about half the time, is that it's a good feeling. I think it's, whether it's TADS or whether it's something, again, with Invisalign, we want to have something that's more accepted as far as appliances and growth, because people care. In other words, I feel like people do care and they have the knowledge and they want to help. So it's like, we call it non-compliance or less compliance. There's always compliance.
Right.
I can appreciate what's happening as far as like, okay, we're not going to put biometers in kids. It's a giant mouthful. I did one here and I don't know how they get even more. Headgear by plate, stuff like that can definitely work, but things that are more accessible and more in our control so that we can do things better for the kids. So I mean, I feel like everything's going in a positive direction.
Absolutely.
The older literature is like, okay, you read that and it's like, yeah, they can fight and they're slowly dying off. So it's not. I didn't mean to think that it was a bad thing.
No.
Overall,
Yeah.
I think that's life in general. Hey, how can we make this more accessible to more people and more, even though we know the limitations, but
Exactly.
Make it a better appliance.
Yeah, and I think the majority of that conversation really helps the pediatric dentist, right? Because you guys aren't as exposed to this world of what we're taught in residency versus like practice versus like how that dynamic works from, there's tons of stuff in pedo dentistry that we're not either, right? I mean, like you guys have your own little, battles of what the heck do you call it? The thing that turns things black. Yeah, like that versus, you guys have your own conversations that we're just not aware of, right? So I wanted to kind of bring you up to speed as far as like how we as orthodontists process some of these things. But like I'm going to try to keep this lecture simple so that, hopefully when you walk away, you at least have a bird's eye view of what functional appliances are, how they work, schools of thought between the two. And the simplest way that I can boil these down is basically fixed and removable, right? So, we understand fixed. Dr. Hill made a nice comment about my hair. I would hope my hair is fixed. Not everybody's hair is fixed, right? So some hair is more removable, right? So, that's boiled down the functional appliances. That's kind of the two broad categories you can put them in. And then that way when you're analyzing an appliance, you can at least put it in one bucket. So like Invisalign MA, would you call that a fixed or removable appliance? Yeah, removable, right? You take it out, they eat, all that kind of stuff. So let's go back and look at this functional appliance. Does anybody know the name of this functional appliance? Yeah. So this is a binary. It's a type of monoblock. Okay. So monoblock is kind of like the big picture category. Anybody know when these were invented? 40s. 1902. Okay. So the concept behind a monoblock, and the reason it's called a monoblock is pretty simple, right? It's just one block, right? So monoblock, pretty easy. So anything that's kind of like one block, you can group most likely into the category of monoblock, right? If it's a functional appliance. So this is a monoblock treated case, okay? So now when you look at that, and again, I haven't showed you the teeth, I haven't showed you anything else, but you look at the changes that you see here, would that be easy to achieve for any of the orthodontists who have treated comprehensive class 2 cases like this? Would that be easy to achieve with elastics or springs, or like for me it wouldn't be. That would be very, very difficult, okay? So am I saying that they grew the bone or anything magical happened or that the patient wouldn't have grown that way anyway? No. I mean, this is one case, right? That's why we do research and have studies. But when I look at that, I'm thinking, that's interesting. Okay, so bionator, activator, same kind of thing. It's like that might be a decent way to get there. Now, to Dr. Hill's point, what I didn't tell you about that appliance is, because it's a monoblock, what does that imply? You can't do anything with it except have it in your mouth, right? It's going to be hard to speak with it, although some kids can somehow. You have to take it out. People are going to see it. I don't know anybody doing these personally now. I mean, there's other things, right, that we'll go over. But if you're just talking about like what can it do, yeah, it can do some pretty cool stuff, right? So what about this one? Anybody know what this is?
Herbst.
Yeah, Herbst appliance, okay? There's lots of different variations of Herbst appliances, but the basic concept between a Herbst appliance, first off, is it fixed or removable? Yeah, fixed, right? It's hooked to the teeth. So the basic concept of a Herbst is that it creates a situation where your mandible cannot drop back when your mouth is closed, okay? Now, if your mouth is open, different scenario, right? I mean, you can open wide and you can seat your condyle that way, but it's essentially keeping your condyle out of the fossa. Now, the theory, and back to Dr. Hill's point, the theory behind this is that if you keep the condyle out of the fossa, you are essentially keeping tension on the condyle. That's the thought, right? Now, is that true? I don't know. But if you have the mandible forward, that means the disc and the discal tissues that encapsulate the disc. I mean, that's connected to something, right? It's all back there, retrodiscal tissues. I mean, you can't just like pull your jaw out, right? It's connected, right? So it makes sense that there's tension. Now, is there enough tension on the condyle, which is a growth center, right? We know that there's growth happening at the condyle. So is it enough tension to actually make a difference in the length of the condyle that otherwise wouldn't happen? There's the debate. Up to this point, the consensus has been no. And that really all you're doing is speeding up that growth. And so you have it now. And then that's just kind of growth that you take away later, like they would have grown that way. But even if that's the case, let's just say that we speed it up and we don't really get any overall mandibular growth, or at least not a hugely significant amount, maybe less than a millimeter, let's say. I would argue that that's still a really nice tool to have while you need to treat a patient, because patients don't want to wait till they're done growing to be treated, right? They don't want to be treated in high school a lot of times. They don't want to be treated in college. So if you can, even if it's just capturing the growth a little bit earlier, to me that's a huge benefit, because now you can treat a patient earlier and they can enjoy the benefits of treatment, namely looking better, having a better bite, socially. They can enjoy all those things earlier. And if there is an actual outright benefit from a skeletal standpoint, which again, no one in here can tell me 100% if that is or not. We don't know. Our best knowledge is that it's not as big as some people say it is. But if there is that benefit there, then that's just a bonus. All right? So that's how I think about it. Is the Herbst, anybody know when that was invented? First one? Pretty close, 1905, okay? So these are the parts of the Herbst, right? And this helps us to understand how it works. This is they have Herbst that go from molar to molar, so the main support's happening on the molars there. You can also have it hooked up to bands on the lower premolar, so there's different ways to design it. But you have your telescoping wand. It has to be telescoping, right? So you can actually open and close your mouth. So there's not like springs in there. It's just telescoping, and physically when it's all the way telescoped closed, you can't go back further than that, right? So you can activate this by adding shims, and when you add shims, which is what you see there, then all of a sudden as it closes, it cannot close by that much more, so it advances a little bit more forward. And you can do it right versus left, advance this side more than that side, and you can try to shape the growth or the teeth or whatever you're trying to move until you get it where you want it, right? And so this is a newer design. I believe it might have been Ormco or somebody that came out with this. I'm not 100%. I think it's called Advanced Sync. Is that Ormco? Do you guys know? Or is it still around? Have you guys even used this? Okay. Yeah, so this is a molar to molar. Same idea, just a little bit less bulky. But with every appliance, and why you have so many functional appliances and really so many Class 2 and Class 3 appliances in general, if all of them, if there was a perfect appliance, there would only be one. Right? So all of these appliances have limitations and side effects. And so basically practitioners decide which ones they want to use based on which limitations and side effects they dislike the least, right? And so with Herbst appliances, there's a lot that can happen, okay? So like look at this patient here. Now this is a before and after. This is a side effect, right, of a Herbst treatment, at least in this case. So is this an acceptable side effect? What side effect am I talking about? What are you guys seeing? What side effect am I talking about? Okay, yeah, potentially. Well, why do you say dyslies in the upper? Because you can't see the teeth, so you don't know that. So why do you say that? What are you seeing? Yeah, you see the nasolabial angle, right? Ooh, there we go. Yeah, you can see how much more obtuse the nasolabial angle is after treatment than it was before treatment, okay? So is that a side effect or limitation that you're comfortable with? Maybe, maybe not. Right? So the teeth are fitting together. I didn't show you the teeth, but we can go through it. But the profile is different. Is that worth it to get the result that you got or not? These are decisions that you have to ask, okay? So 9 years, 5 months old, this is what the teeth looked like before. You can see there was quite a bit of proclination, quite a bit of overjet, right? Maybe lips getting trapped underneath those teeth. That's probably not helping. What else are you noticing just from a, like I say, not a lecture on airway, but just like, is there anything else that you notice that may just make you a little bit suspicious that maybe sleep, you'd want to look into sleep or at least ask questions about it? Like, what do you see? What's that? Yeah. Where do you see the gingival inflammation? Where do you see the most gingival inflammation? Yeah, on the tooth. So now we talk about gingival inflammation related to open mouth breathing, usually in the anterior, right? So you're breathing in and out through your mouth, and it tends to dry that up. Now, what's different about this case than our typical anterior gingival inflammation case is you really only see it on the laterals. So if this wasn't airway related, why might they only have inflammation on the laterals? Yeah, right? They might have just barely lost that baby tooth, right? The tissues may, and honestly, like looking at this, that's probably the case because you're not seeing it other places. But you also see a little bit of chapped lips, right? So probably a mouth breather. Does it matter? I mean, like, I believe it is. I don't go around telling people like, you know, oh, if you're a mouth breather, your jaws are going to be messed up because there's not research to support that, clearly at least, or definitively, right? But all the science that I understand and know, like if I'm a mouth breather, I'm going to try not to be. I mean, one of the downsides of speaking is that you're a mouth breather, right? So I'll notice, like I get done giving a presentation, and especially like 2 or 3 hour ones, and it's like, oh man, I just like need some water. And then I'm like, man, I'm kind of like getting congested already, right? And so I try not to be a mouth breather. Sometimes we have to, right? Speaking is kind of important. But at night, you know, I lip tape. Like I definitely believe in the benefits of not mouth breathing. And so I will recommend that based on my experiences and the benefits that I get from that. But you get into trouble and you kind of give our profession a bad name when you present something as authority or dogma that there's not evidence to back up. So here's our after results. I mean, beautiful smile, right?
Looks good.
So not my case. This is a lot of these are not my cases. So this case was, there was a really cool platform that doctors could share cases with, and long story short, they went out of business. But it was super sad because you could filter it through all the different appliances that were used. So this was a Herbst case. You know, I'm looking at the smile. Like if I had to pick between the two, if it were me, I'd want to walk around with that one. I'd want to walk around with that bite, you know, but the profile's not as good. It's a limitation, side effect question.
This might be an amateur question, but how much of it, like the nasolabial lining or the angle, is affected by the growth of the nose? Because her nose is different from when she was a child from there, you know? How much changes with that?
So what I will tell you is that most orthodontists don't know how to answer that question, right? I'll put myself in that bucket. Because in order to answer that question, you have to know a lot of different things. One, you have to know what normally happens with nasal growth, right? What does it normally grow 1 millimeter per year? Does it normally grow 0.5 millimeter per year? And let's just say you know that, like you know the nasal growth, right? Then you have to decide, well, does this patient grow normally, right? Have they demonstrated normal growth? So did you see them like 2 years before and you measure like from there to 2 years later and you saw the trajectory of their growth and now you took that time point from beginning of treatment to after treatment and you factor out what would have normally been. That's why these studies always have limitations, because I can't answer that question for you. When you look at it, yeah, it looks like the nose grew forward. That may have had an effect. I mean, just the dental position, none of us would want those teeth flared out like they were. So how much would the profile have changed just by moving the teeth back versus by moving the teeth back and doing a Herbst, which maybe moved the teeth back further? I don't know. So those are all questions that are important to ask, but unfortunately, we don't have answers to. But the better data we get, the more answers we start to get. That's why, like, pretty much all the research that we're still being taught is based on two-dimensional information that we had. Not that two-dimensional information is not valid, right? That you can validate a lot of things on two-dimensional information, pan-ceph. But now we have the ability to conglomerate large amounts of three-dimensional information, right? So things like projection of on a larger scale. We've had like photo cameras and stuff in the past that you could do facial shapes, like that's been around, but nobody used them. We have widespread use of cone beams now. So we have younger kid cone beams. When they get a little bit older, treated, not treated, like the data's there. And the research that's coming out is putting us in the direction of learning what's happening with these things. So as more and more studies continue to be published, we are going to learn more about the three-dimensional growth of the patient. And in my opinion, that's going to be what helps us drive the consensus of our research forward and learn things better than we've been able to in the past.
Two things for you, Justin. Number one, if you're interested in soft tissue aesthetics, you should read something about orthodontic surgery and all that. Like the McLaughlin Arnett book is very straightforward. And you'll get there, you know, when you're here in the program. But it's really interesting to see a lot of the surgery, they'll reposition things. It's not going to talk about necessarily growth and development, but to have how the soft tissue and the outside of everybody's face is affected by the bony position of things in the teeth. And then number two is, like Jeremy saying, or Dr. Manuele is saying, is that it's very interesting. This is how you learn. You see, let's say you see dozens and dozens of things, either online or you see it in your own practice or somebody else, and you say, well, this is going to be a comparison that I do just mentally. Like, okay, this seems like it's happening in a lot of these Herbst patients. Is this an acceptable thing, or how do I minimize that effect, whether it's an upper lip? The good thing is most people's profile is irrelevant not only to them, but to everybody else. We're focused on it for certain reasons because we care and we want to know how we can make everybody great in 3 dimensions. But, you know, this is much more important than this. Most people don't look good in profile, I don't think. For some reason or another, they can be extremely attractive because you don't look at somebody and like, I'm not staring at this guy looking at his profile going, oh wow, you know, he's retrographic, his lips stick out too far, his nose is too big. You know, you don't see that. I mean, but this is how you learn. You see all these things and you just kind of take it together and say, well, that seems like a lot of these Herbst patients, this seems like something that is, but is that an acceptable compromise? Because you want the teeth, like you said, you don't want the flaring of the insiders. You want the exclusion. You want the big broad smile. And if that means that, okay, she's got relatively flat or thin upper lip, so be it. That's not going to affect her negatively. But if I don't do these things, she's going to have bad smile, bad arch, you know, So that's a lot of this job, is just hey, this is going to be with this, not a side effect, but maybe a small thing that I can't fix or I don't know what's going to happen. But that's the whole fun of the job, is to figure out how can we minimize so everybody gets everything just right, which will never happen.
Right. And I would totally agree. Most people don't care about the profile. It's not like a big deal. But the other side of that coin is that it's becoming more and more of a big deal. Not just the profile, but exactly, because everybody's their own expert. You have so much, influencers out there having entire channels dedicated to different cosmetic procedures that can happen. So people are learning. I mean, there's a YouTube channel. It's called Jaw Hacks. It has 40,000 followers. So this guy went through a MARPE treatment to make his jaw wider, and he just sort of started blogging about his experience. And long story short, like over the course of a number of years, like there was so much interest, people kept, like he turned it into like a job basically. And this guy knows more about MARPEs than most orthodontists, hands down. Like, does he know everything else that an orthodontist knows? No. But he knows more about an orthodontic, technique than most orthodontists do. And that's the reality of the world that we live in, is information is accessible. So now more than ever, I mean, you used to just be able to like, hey, do your thing. Like, yeah, I mean, this is what I do and how I do it. But you will get questioned from patients in private practice who are knowledgeable about certain things. So you kind of have to be more knowledgeable than you ever have had to be in order to answer those questions intelligently. Because if you can't, they're going to know that. And they're just going to be like, okay, well, yeah, cool, I'm not going to go to that guy, right? So yeah, it's interesting. It puts us in a different, I mean, I think it's I think it's a net positive overall, because we should be learning everything that we can and abreast of the, like, that's how I've learned a lot of the things that I've learned, is a patient came in asking me about something that I didn't know about. Well, that sucks, you know what I mean? So it's like, and not all of it's orthodontics, right? Sometimes it's sleep medicine, sometimes it's, something else. But I'm like, hey, I'd never heard about that, and so I want to research it, like, because what about the next time somebody comes in like that? And that's how you build your knowledge as a practitioner, in part, because there's no way you can research everything, right? You're not going to know everything about everything. But as you see what patients want to know about, then you can focus your efforts on what's important to them. Okay, before and after panel. All right, so you can see the process here. So this was a Herbst done in the mixed dentition. All right, this is a different case. All right, you can decide, was the sacrifice worth it? Not as much change in this as we saw in the other one, right? Okay. What are the other side effects of a Herbst? Anybody? What's one of the major dental problem side effects with a Herbst?
Proclination of the lowers.
Okay, proclination of the lowers, certainly something. Is that super hard to address? Can be. What else is a hard thing to address post-Herbst?
Bite opening.
Yeah, specifically posterior bite opening, right? And depending on the design, that's going to be more of a problem than not. I remember watching Dissinger, and it's funny because Terry Dissinger, the father, he did a ton of Herbst, and then Bill is like, he's like moving more toward like aligners, MA, like, almost moved away from it completely. But his dad, I remember watching a webinar, and like they would put these Herbsts in, and they had like an RCOS wire in the lower, and then a utility arch in addition. Like they were just doing everything, like throwing the whole 9 yards to get that lower arch to level, to intrude the incisors so that bite wouldn't open as much. Because, mechanically it makes sense. I mean, you have something there's a vertical component to those forces in addition to a horizontal component, and that's going to express. So you can see how hard how difficult that can make it. The upper teeth can sometimes tip back, and this is not the best example because these teeth obviously started tipped back. They're actually probably tipping forward now. But the more you push, the more you have to retract, the more that the upper teeth are going to have to come back, the lower teeth are going to have to come forward. But what about the airway? I mean, is it going to have an effect on the airway? Again, these are controversial topics. I mean, obviously in this patient, it looks like there was a pretty dramatic change. Now, things we don't know, like was the patient swallowing, not swallowing? Like, I don't want to get in a whole debate about how valid or not valid this is, but it's an observation. The cervical spines seem to be in about the same location. It doesn't look like one's super, more forward than the other one. It's like, okay, did that airway change actually manifest as some improvement in their quality of life? I don't know. Like maybe, maybe not. You have to ask the patient. But again, you want to be aware of the types of changes that you're seeing, and having 3D allows us to visualize these changes in a way that we never used to be able to. So who knows what this appliance is? And this, I would say, is not necessarily even considered a functional appliance in some circles, although it can be used that way. Does anybody know what this is? I used one of these in residency. And typically you use it when you're getting close to completing an orthodontic case, and you don't want to do a ton of... Yeah, positioner. Yeah. So do you know when those first came out?
A long time ago. That first thing.
1944, right? So a positioner traditionally used, basically the concept behind it is you send your models, stone models, to a lab. They cut all the teeth off and position them in the most ideal way, tips, torques, rotation, and then the kid wears this thing and just bites into it. And like as they chew on it, it helps correct the teeth. Actually worked very well for at least one of my board cases because there's only one way for it to go. They have to be compliant. If they're not compliant, the teeth don't move. The inside's kind of squishy, but you can set it up either as like a type of retainer afterwards with a slight class 3 force. If you're trying to keep a class 3 grower from growing too much, you can set it back a tiny bit and it's spongy enough that they can kind of bite into it, put pressure to distalize the condyle. I'm not saying that's a good idea, but it can be done. And then you can do it the opposite as well. Like if they're class 2 tendency, you can set it a little bit more forward, so at least when they're wearing the retainers, it's pulling that forward. Who knows what this is? Yeah, Frankel, right? So who's done a Frankel? Anybody in this room? Yeah, I didn't think, I haven't either, right? So does it work? What's the concept behind it? Is it fixed or removable? Yeah, removable, right? So I mean, and this is kind of like the definition of trying to be removable, if that makes sense. They tried to put as little on the teeth as possible. So the idea behind the Frankel is that we want to keep all of the bad forces in the mouth off the teeth, and Mother Nature will do what she's supposed to do. It does the way that it's designed, especially for class 2 patients, and they do have class 3 Frankels as well, but especially for class 2, it makes it to where if your jaw is not like forward, then it's uncomfortable, right? You're hitting all these pads and stuff like that, so you kind of have to keep your jaw forward where it's supposed to be in order to wear this. And then they have these buccal pads, so that's going to shield the cheeks, right? So the cheeks aren't pushing in on the teeth, causing them to actually move lingually. So basically, you're taking off all the bad forces of the teeth, and you're left with supposedly only the good forces, so the arch can develop normally, rounded out, all those things. And you can see there we have the cross arch stability there, also a place to have your tongue go up to the roof of your mouth. And basically, it's just basically a field goal post. Labial bow. And this is a Frankel case. Again, not my case, but do they work, right? And again, I'm only showing you a profile photo, so he could just be moving his jaw forward. But there's lots of practitioners in the past who have used Frankel. You can see how old that photo is, right? Like nobody uses these. What about this one? I didn't even know what this was. I'd never heard of it. I guess it's called a double plate. And that came out initially in the 1950s, but it was the precursor to one that still today people use. Any ideas what that might be? Yeah, exactly. So twin block, right? So twin blocks are a pretty versatile functional appliance. You can do more with it than just move the jaw forward. Anybody know when those were invented? Relatively recently, right, compared to the other ones, so in the 70s. And you can see this design is designed to also expand. Now, is it going to expand orthopedically? I don't know. Probably not. Right? Most removable expanders, especially in kids that are old enough to be having a functional appliance, have not been shown to have a lot of orthopedic change, mostly dental-alveolar change, right? But at the same time, you've got Invisalign coming out with a product specifically designed for even younger kids. I mean, could be even 4- and 5-year-olds, where it's a removable appliance, and supposedly they're showing orthopedic skeletal changes. Now, I haven't seen enough before and after, before and after cone beams to really appreciate or understand that myself. And if and when I do see those cone beams, the first thing that's going in my mind is how much of that is normal growth? What was the interval? When was the first cone beam taken? When was the second cone beam taken? Or are you actually seeing a sutural split? Did you take a cone beam in the middle to actually verify that that's what you did? The problem is, we don't like taking a bunch of cone beams on kids, so we may not have that data for a while. But again, you have to think about the appliances that you want to use, and is it worth the risks or side effects associated with them?
The twin
so
block
this is the twin block.
A removable appliance utilized to correct a class 2 bite.
They need to make these things flavored so the kids will just
Right.
just be like, oh, I'll take one of those.
Another challenge with mixed dentition is the teeth are erupting, right? And so you might be exfoliating.
The expansion component of the twin block gradually expands the upper palate, creating space for the front teeth to be moved back into position. The impact of the upper and lower pieces of the twin block drives the lower jaw forward, correcting a class 2 bite. A portion of the acrylic on the twin block is ground down to allow for the eruption of the back molars.
Managing side
The final
effects.
stage of treatment with the twin block is the placement of an inclined plane retainer. This appliance allows for the further eruption of the rear teeth to conclude treatment.
So I have not, has anybody done a twin block in here? Yeah. So I mean, at University of Houston, they do a lot of twin blocks there. This case, I believe, was from Sean Carlson, and he's not like a twin block guy, but like for difficult cases, severe centimeter plus overjet, that was a tool that was in his tool bag that he used. This was a case that he had presented, and you can see like quite a big change. Like that would be difficult to get to. Now, just like anything else, he had a protocol, procedure, he had systems in place to make this successful. He knows the side effects, he was able to manage them, and he can get a great result with it. And I look at a case like this before I was doing any type of functional appliance, and I didn't really have anything in my toolbox that I could be like, oh yeah, I can predictably get that. Like that was a challenge. Like cases like this were a big challenge for me. Okay, so what I love about Sean and this whole thing is that he went through and made sure that all of the documentation was there. So you could literally see the changes in the bones in 3D superimposition form. So you can analyze and see, like, what do you want to look at? You can see all the before and afters. I mean, you could go back and measure it if you wanted to. Like, is the jaw bigger? Yeah, I mean, it's certainly bigger. Would it have grown that way anyways? I don't know. Like, research says that it probably would have at some point. But there's no way I could have gotten that patient from there to there in 2 years or whatever it was with the tools that I had, and so I was like, okay, this is something that I want to look more into.
Well, what's interesting, and sorry to interrupt for the third thousandth time, but this tongue position seems extremely important in a lot of these kids when they're developing growing. Now, we can get into that mewing stuff when you're an adult later on, if you're going to play with a man than you did before, or your jaw going forward. I don't think that's the thing, but it's really important. Like, once you get this transverse, and you can get that mandible down and forward and widen everything out in a growing individual. I mean, that's when I stay up at night. I think, okay, how muscular is my tongue? Well, I must have done growing, but how much did it influence? Like, I was a finger sucker, and for years until I was 11, and I mean, a very constricted maxilla. But it's like, it's great to have the tongue up there because we see this all the time, whether it's upper airway, lower airway, whatever. The problem is if the tongue's not up in the roof of the mouth, maxilla's not going to develop transversely, and then that affects, I think, the mandibular growth and then the teeth eruptions and everything's crowded. So these are, like you said, a lot of it's just put something in there.
Okay.
And let's do it.
I love this.
Get it going.
I love this. So, who here thinks that Dr. Hill came out with a new appliance that helps you keep your tongue on the roof of your mouth, and that's why he just said all that stuff?
Oh, yeah.
Right? So think about this. So he just made a statement of something he truly believes in, right? And I agree with him. I believe in that as well. That being said, how many randomized controlled clinical trials have you seen or read that demonstrate and prove what you just said? Like none, right? And so, and there it is. It's like we learn these things that make sense. If it were us or our kids, that's what we're going to do. But try to design a randomized clinical control trial for that. Like, how do you even design it? Like, how do you know if, like, where the kid's tongue is, like, all the time, or how long it has to be up there, like, where, like, 24 hours a day? How do you design that trial? So we may never have that information. So we have to make decisions based on the information that we do have and what makes sense to us. And 100% I agree, right? And so we want to get, like I say, I try to make room for the tongue. The other thing you didn't mention, but this is kind of, if any of you get this question, I'm going to try to ask in a way where it's not super easy. But what is the only functional appliance that I can think of that doesn't require anything in your mouth, right? At least while the functional portion of it is happening, and doesn't require you to wear anything. And it kind of goes along with what he was saying about the tongue a little bit. What's that?
The tongue.
So, okay, so my point is the teeth are a functional appliance, or they can be. And here's what I mean. So teeth, when they come in, they're designed to fit a certain way, right? And your jaw goes to where your teeth fit. Why do they go to where your teeth fit? Because that's how you chew. So if you alter, let's say, even one of the jaws, right? So let's say you alter the upper jaw and you make it wider, all right? Now the teeth don't fit so well where the jaw was, right? Because the lower jaw was set back to match that upper jaw, which is more narrow. Well, now the upper jaw is more wide. How do you get the lower jaw to be more wide if you don't move the teeth out? What has to happen in order for it to have a wider portion of it connecting with the now wider maxilla? It has to come forward, right? You shape them more, the lower jaw comes forward. So now all of a sudden you put them in a situation where their teeth fit more comfortably together when their mandible's forward. Now, does that mean that if you do that, every patient's going to posture forward? No, right? I mean, some may just hit on the back because that's where they like to chew and they don't really care that their teeth aren't fitting well there. But it's interesting, worth thinking about, right? I mean, like, even if that happens in a small percentage of your patients, that's kind of a cool benefit that requires no compliance or nothing else, just making the jaw on the top the right width and allowing the lower jaw to come forward to match it. All right, so these are the airway cross sections. You can do 3D superimpositions to see the changes of the teeth. Like you can look at the jaw. So this is kind of more superimposed on the chin here, right? And you can see the changes in the length and the body of the mandible. Now, the question, of course, is how much of that would have happened with normal growth? Again, really hard to design studies to definitively show that. So here's the changes in the profile. Not as, like, definitely an improvement, but look at the nasolabial angle, kind of similar thing, right? It's become definitely a little bit more obtuse. The lower jaw didn't come, at least from a profile standpoint, as far forward. All right, if you're interested in using twin blocks, this was the design that he used, posted all that. These were his protocols. I was actually thinking about doing one of these, and I ended up going with different functional appliances. But that's, if you ever want to do a twin block, you can just capture a picture of that and try it out. This is one that I still use. And anybody know what this is? Yeah, MARA. And what does it stand for? Yeah, I think you got it. Mandibular anterior repositioning appliance, right? Anybody know when this one was invented? There you go. Newer one, right? 90s. Okay, so what is the MARA? I mean, in a lot of ways, it's very similar to a Herbst, right? There's metal that causes the lower jaw to go forward. But instead of having those telescoping wands, basically, this is active when you bite down, right? If you open your mouth, your jaw just drops back. You can drop back behind those metal bars. But when you close your mouth, it will push the lower jaw forward. I think we have a video on this. So normal bite, you can see they're class 2. Put this in. You can see those on all these appliances. Look how beefy the bands are, right? And you can do them with 3D printed bands, which is what we do now. But like, or Rolo bands where you can take a scan and then place separators afterwards, right? But you need something beefy because that's a lot of force. So if they try to bite down where their jaws normally would go, they can't. So they have to move forward, and then you can continue to activate it by adding shims, right? So you add another shim, and that moves that bar forward, 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 until you get them to the position that you want. You can design these in different ways, right? If you need dental or skeletal expansion, you can design an expander Hyrax on the top or something on the bottom to move the teeth outward, all right? So that's a MARA. I use those still sometimes for severe cases, right? It's fixed, not really, pretty much non-compliant, right? You have it in there, and unless you just sit there with your mouth open all the day long, I mean, I guess you need the compliance of actually keeping your mouth shut with your teeth closed, but other than that, you don't need it. So these are the mandibular advancement features that are currently out there. So the top left one is Invisalign's MA product, although I heard that they're actually moving away from this more toward that bottom right one, which is Angel Aligner's mandibular advancing product. Now, I have not, I'm only just now starting my first Angel Aligner MA cases because it's only been around for like this year, right? So, but the idea is the same. In my opinion, just like those other, Herbst appliances and everything else, there's always side effects. And one of the problems with the Invisalign one is posterior open bite. So we'll finish up here, and next time we'll jump back into the list of all the fixed and the removable, and then we'll go through a couple cases, just my cases, to again share with you my experience with them. And then if we want to go over board questions after that, so you guys can learn how good or not good you did on them, just send me the questions that you guys have, a question bank or whatnot, and we can have a discussion about it. So awesome.
That was great, Doc. Hey, you know what's interesting? I was hearing, you remember Bob Danforth, Dr. Danforth?
Yeah.
So he told me, we were in class, and everybody wants evidence-based, and there's obviously that's important, but it's not the only thing. He said there's no RCTs for parachutes.
Right.
Nobody's going to be in the control group without a parachute, but we know that it's good